I am so happy to welcome Jared and Dr. Guybe with us today to talk about Health Talk AI. So Jared and I had a conversation. I got to learn a little bit about the product and I was so enthralled. It was one that I really wanted to be able to do a vendor feature and show it to others. So let me do a little bit of an introduction about our event today and then about both of our speakers, and then I'll hand it over to them. So, Health Talk AI was formed to change the way healthcare organizations and patients connect. Their platform removes administrative workload and improves the patient experience by digitizing intake and automating outreach and scheduling. This allows clinicians and staff to work at the top of their license and fill their schedules with appointments their patients need, improve operational efficiency, patient satisfaction, and quality with Health Talk AI. So Jared has quite the background. He's the CEO and founder of Health Talk AI. He also started his career at the bedside working as a neonatal intensive care nurse. And so he understands healthcare. And this is one of those products that when it's built by somebody who truly understands the need and the opportunity and can wear both the business side as well as the healthcare practitioner side in the creation. And I just love that. So, Jared has over 20 years of clinical and healthcare product management experience, defining, building, and supporting market leading software and health information technology. His blend of product management and healthcare subject matter expertise allow him to continue to shape solutions that resonate in the healthcare market. We're also privileged to be joined by Dr. Tanvir Gaibi. He's the chief of experience medicine at Innova Fairfax Hospital in Falls Church, Virginia. He is responsible for leading emergency departments across 5 hospital systems and impacting over 400,000 lives with direct oversight in operations, direct reports, and P&L. He brings an established track record of financial impact and leadership, working closely with executives and the board at Innova Fairfax to improve operational quality, affordability, and the patient experience. We are going to hear today how Health Talk AI has been used by Dr. Guybe's team and what they're seeing as a result. I love that when we actually see somebody who's using it and can tell us their story. So I'm just thrilled with that. So just finally, I want to let you know we're going to have a presentation about the tool, and then we'll have plenty of time for open Q&A and discussion. At the top of the hour, we'll transition to speed networking, and I'm really hopeful that you'll stay. Both Jared and Tanvir are going to stay, so that would be an opportunity for you to have a further conversation, get to know them as who they are, but also ask some other questions if there was anything else you wanted to learn. So with that, Jared, I'll take back over the rating room, and I will hand it over to the two of you. Thank you so much for joining us today.
Absolutely. Thank you for having us. And really today is going to be a case study, and Dr. Gabi will be kind of leading it. I'll be here to answer any questions. And I love the format that this is a talk with and a talk to. It's kind of how I run my webinars as well. So if there's any questions, just chime in, and I think it's an open mic, right?
It is. It is.
So yeah, so just chime in and we'll answer the question on the spot instead of trying to remember to answer at the end. And if some of the folks can't stay longer. So with that, Dr. Gabi.
Yeah, thanks, Jared. Let me just, so now you guys can see the slides. That's me.
Yes.
Okay, so during our talk, we're just going to cover the background of Innova Fairfax Hospital, some of the challenges that led us to working with Jared and his team, and how the program has really kind of impacted us, and what are some resources that were available along the way as some unforeseen challenges like COVID popped up. So it's a little bit about us in a nutshell. We're one of 5 hospital system. We're the tertiary flagship hospital of the Innova healthcare system. Our ED specifically at Fairfax sees 160,000 visits. We're actually on pace for 170,000 this year. Maybe some part due to Jared, because patients really have enjoyed coming to see us. So we're level 1 trauma center. We're comprehensive stroke vascular center, and we do basically everything except kidney and liver transplants. We're also a teaching hospital as well. In the 1,000-bed hospital, we have residents and learners, nursing learners, resident learners, med students. We're the secondary site for UVA. So it's a nice, complex place. And our patient population is a pretty diverse patient population. The running joke with us is you can come in, you'll get a retired Supreme Court justice in one bed, and then in the other bed, you'll get, someone who just landed straight out of at Dulles Airport. So you can get a variety of everything. We do 70% of our patients do identify themselves as having at least a bachelor's degree, and we do have about 20% patient population who English is not their primary language, so we do use interpreters as well. Some awards just to kind of give a flavor of it's DC. There's politics. all these merit badges matter, but we do take pride in a lot of the quality that we deliver. So we're, across the system, we're recognized as a leapfrog A, and you see some of the other recognitions that we've received. The hospital itself is a pretty high acuity place, as we talked about. It's a tertiary quaternary care center. So in the adult side, which sees 110,000, and the ped side it sees 60,000. There's a 30% admission and observation rate, and so there's rapid evaluation at every age. Where you see all the services we have and the beds we have. So you guys are maybe saying, how do you guys get 170,000 visits through 85 treatment areas? Well, 40 on the adult side, we average about right now. We're averaging 310 patients a day. 40 in beds and 35 in hallways. So as you can imagine right there, that's a problem right there. And so when you talk to the team and we were starting to struggle with patient experience, the team would say, Tanvir, Inova, like we're seeing half the patients in the hallways. Do you realistically think that our patients are going to be happy? There's no way they're going to be happy, right? So, factors that always drive patient experience, and these are being amplified recently, is boarding. I know all of us are dealing with boarding, and I'm sure a lot of your team members tell you at the hospitals that you're representing, boarding is an issue. We've had some increased volume post-COVID. Everybody said emergency, during COVID, everybody thought that the volumes are going to be taken elsewhere. Everybody thought virtual is going to be every day, but it's not. So we've seen a big spike in our volume, big spike in our mental health patients. And just like with the Great Resignation, we saw staffing challenges in nursing and ancillary support, which are now starting to come back, but it's still a challenge. We're all pressured with, reduction in premium labor. So we found all these issues, there's so much noise out there, and it was really hard to say, okay, what's the one thing? The staff say there's not TVs in the rooms, and what are the patients really saying? How do you get to such a big patient population in a timely, actionable way that can really drive changes? So, one of the things that this, the way we, when this really arose, Jared and I got introduced through some mutual friends, and I said, Jared, these are the problems I'm trying to solve. Our patient experience scores are low, and in DC, people expect a lot, especially when you have 70% of your patient population who has a bachelor's degree. And this is an educated, mobile patient population that can go elsewhere to get their care. They can drive, they can do whatever they want. They have good insurance mix. This is not the patient population that's just going to sit around and accept, the current state. So that's what we can, Jared and I started talking about what, HealthTalk could do and how we, leverage it and mobilize it. So we really kind of created a process to, call back to help identify quality. So as you'll see in the next few slides, what HealthTalk does is it's a mobile technology platform that is really user-friendly and adaptable to whatever the clinical site of care needs are. So the way we utilized it was we basically, every patient who gets discharged from our emergency room, they get a text, and then the text will opt them to answer part of the survey. And then we as you'll see, we have a couple of questions, and some of the questions were driven by frontline staff. Well, what we said is let's engage the frontline staff in what they think are going to be very meaningful. Our healthcare system told us that their number one initiative, what they want to know, is the likelihood to recommend. So as these texts went out, that was their opportunity to engage back with us, and kind of the couple of questions that we came up with that were developed by the staff. So there was some buy-in from the staff. And then number two was an opportunity for the patients to free text as well. And then we really monitor those comments and help identify issues. So it helped identify process and people issues. It increased provider connection with patients. All the providers are able to log into their own and see what interactions they'd have and what patients are saying in a really timely fashion. And it gives leadership real visibility into what patients are saying about us. Ultimately, there has to be ownership. It is ownership of the leadership in this example. The ED, the nursing physicians, really need to own this and say, this is our baby, and we have to take a lot of pride in what people are saying about us. And then opportunities to really mentor. I think culturally things have changed a lot over the 20 years I've been in medicine. In the beginning, it was like more like you get hit over a hammer, but now conversations have really evolved into more conversations saying, hey, what do you think the patient meant by that? What are the opportunities? So really kind of mentoring at-risk providers, because it's not like it's not like the supply-demand curve is such that you could just replace somebody the next day. And then improve and sustain patient experience metrics. So this was like a little timeline of how we started in 2019. We started doing some leadership in the ED, started doing some callbacks. So there's an option. It's very customizable where it'll ask you, if you score in a certain way, would you like a callback from somebody in leadership? And they'll give you a window of when they can make the callback. So it's really connecting the patient and the provider, making sure that you connect on time. So it'll give you, in the beginning, when I was initially doing a lot of the calls, they gave a window saying, here's when I'm available, let's connect. And then, we connected, no one's time is wasted. And we get a lot of good insight into what some of the issues were. Then during COVID, 2020, we implemented some telehealth COVID. So as we were being asked to possibly discharge more and more patients home to create capacity, we wanted to make sure these patients were safe. So we created a platform where we could have a televisit with them the next day to make sure that they're doing okay, that the oxygen levels are okay. And in 2021, we recognized that we needed to revise some of the questions, because what the hospital and healthcare system really wanted us to focus on was a likelihood to recommend. So now 2022 and 2023, nursing's involved in reviewing the survey. So every Monday, the physician nursing leadership team meet and we kind of go over comments together. So there's a physician who's monitoring the comments and there's a nursing leader who's monitoring the comments. And then Monday we kind of come together. But if there's some issues, we text each other saying, hey, this popped up. You might want to address this. Hey, do you want to look into this case? So here's a sample of the questions that we have, were our discharge instructions clear? Yes or no? It's a simple question. Did our emergency department meet your expectations? Did our doctors, NPs, and PAs meet your expectations? And then you see, then those are the initial questions. Now here with the questions that we have now. So again, this is really customizable to what your unique circumstances and challenges are at your given institution. Everything's local. Some things are more macro, and Jared has a plethora of resources where he can tell you what he's seeing or what they're seeing across the spectrum and what are some challenges, so they can be suggestions of what questions may be helpful. But you may decide, what, this is really our question. People are concerned about privacy. People are concerned about hand hygiene. That's a big driver that we're really focused on as an organization. It's really more about quality. And how do you drive those in those questions? My youngest, had a surgery at Children's Hospital of Philadelphia. And when you went to the pre-op room, it had a sign on the door and it said, did you observe your provider wash their hands? Right. So it's like, and there was like a little survey, you put on a piece of paper and you drop it in a box. It was weird. But so, there's all these other ways that you can really use a platform like this to help engage your patients to understand how the team is performing. So here's a sample of what a survey text could look like. Jared got promoted or demoted. I don't know if he would be promoted or demoted as a doctor. I'm not sure yet, Jared, but sometimes it might be a demotion, sometimes it might be a promotion.
I know, right? Yeah. I mean, I think that the point here is what we're trying to do here is create an opportunity for customer recovery. And what this slide, and I don't know if there's another slide about the appointment times, is we're using a bot technology to engage the patients in their language, and I think we have at least a couple languages there live at Fairfax, but I think we have like 15 languages live across the country. And so what happens in the next screen, you'll see this, is we actually look at Tanvir's resources, and there's 5 or so folks that he does having callbacks that the virtual or the bot actually schedules them a callback if there is an issue. And I think that's where we're helping out, is that, Tanvir's 120 or 130 physicians don't have to make all the callbacks. We're actually finding the ones that can call back there. So yeah, this slide it doesn't depict that, but that's really what we're doing here, is we're qualifying patients for the callback. And then Tanvir talks about, those coaching moments, because the data is at the patient level, which Persani and other folks are not. So I just want to add that.
Jared, can I interrupt and ask a quick question about that? So if I'm hearing right, this survey gets triggered at discharge, and it is text-based, so it's nobody else is having to do it. It's a bot that's interacting, and based off of what they respond, that might trigger a follow-up call. And that call gets scheduled based off of whatever you've identified as availability to whoever needs to do that call.
Yeah, that's right. That's correct. The patient gets the survey the next day, or in Fairfax case, I think a couple of days later.
Okay.
So we're very close to the encounter where the patient understands what happened, and Tanvir can talk about where actually providers remember what happened when it's that close to the visit. And then that's exactly right. The bot, based on their logic, will actually look into. We have a schedule that the providers integrate with their Outlook or with their whatever live calendar they're using, and the bot will go to look at those times and actually then deliver them to the patient, saying, hey, here's when a leader is available to talk to you about your issue that you had.
Nice.
Yep.
Okay. Thank you.
So this has kind of been our journey with patient experience, specific since the physician group kind of brought it on. So we measure doc overall and then likelihood to recommend, and the doctors and nurses kind of they move in parallel, right? So whatever the doctors are doing, usually the nurses are doing it as well, and we really like to think of ourselves as one team, and we really take that seriously. So you see how the scores have changed with time. So Jared, as of September 28th, we're still about 92 and 90. So the scores are really kind of holding strong and holding true today, and we've seen before COVID on the adult side, we were seeing about 250 patients a day. And now we're seeing about 310. So over, post-COVID, we've seen a 20% increase, a little bit over 20% increase in volume. And part of that is we're cannibalizing other sites, other care, other hospitals, which are just not performing well. And,
Can I pause you just for a sec? Because of course, looking at data, is that top box or percentile?
This is percentile,
Okay.
and then it's based off a top box.
Okay. Yeah.
Yeah.
Excellent. Thank you.
Yep. And then, here's an example of what, the surveys look like. Jared has some data here. I put some data here from June 1st through June 15th. Patients were contacted, and the response rate is 21%. Some of Press Ganey sometimes will cap out, based on your contract with Press Ganey at certain points, they'll kind of cap out. And sometimes people ask, hospitals will often ask, well, will this interfere with our response rate? And the answer is no. We have not seen a decline in the number of Press Ganey surveys being responded. So patients are not getting text fatigue. So that was always one of the concerns that people will ask. So as we look at some of the comments, here it is, it felt good to be taking care of real professionals, fantastic care. And then, there's a sentiment around, how much is positive, what's negative. And the beauty about this is, we start looking at sentiments, and I talked about earlier, there's a lot of noise out there. And what we were able to really kind of focus in on is our front end process. Patients really felt better, felt like the front end process was a little disjointed, didn't feel like they saw teamwork. So we actually, the nursing physician team, and we got somebody from the hospital kind of help redesign the process a little bit. And then we think that's been part of our gains in efficiency, and that we're noticing it in comments as well. And then in the back, we talked about half of our patients are seen in hallways. So then really kind of scripting around and making the team much more aware about sensitivities around hallway patients. So for example, what was end up happening is some of the sicker patients who unfortunately end up being our elder patients are in these rooms. So what ends up happening is younger patients, particularly younger women, are in the hallway. So, you get a 35-year-old woman who comes into the ER, real appendicitis. She's in the hallway. It's like, I have a daughter, I have a wife. It's like the last thing you want is that person in the hallway. So it's kind of forcing us to really think about our flow and saying, hey, look, when there are privacy issues, let's tell them we're gonna make you wait a little bit longer because we want to respect your privacy. And that way we can put them in certain types of rooms or we put them in the room and then there's a conscious effort to say, as soon as that room opens up, that we're going to slide them into a private room. Now, some of that looks like it's obvious, but when you're trying to change mindsets of team members, that's when you really need to give them data and show them comments over and over again. Say, look, here's a comment. Here's what they're experiencing. Would you want that? So here, like I said, we look at sentiment scores as well. It's a lot of data you can play around with. Here's some positive comments. This person responsive, got me out fast, got assistance. You're amazing. Thank you. Here's some unfortunate comments. Please check in on patients more frequently. Let them know what's going on. The ambulance brought me in, but I had extreme difficulty getting home. Finally, a friend sent me Uber. So we actually partnered with Uber. And in terms of, before ERs used to have like taxi vouchers and tokens. So we have like a partnership with Uber now to get some of these patients home. So these are like, security concerns and other things that we can just kind of look as you yell out the door. And so the good thing about these comments is you can actually go back and see which patient this was. We can analyze into which room it was in. And then that same day or within 48 hours, you can go to the clinician, the nurse, the doc, the PA, say, hey, what happened here? Walk me through it. Did you know this is what they were experiencing? And sometimes like, I didn't know, or sometimes like, yeah, actually I knew. What could you have done differently about it? And are you comfortable calling the patient? Or I'll call the patient myself and just say, hey, you know what? We saw this comment, we talked to the clinician, they apologize. Because sometimes some of the clinicians, you may not have the most confidence that they're able to field those phone calls. So what you'll do is then you'll make the phone call yourself and say, hey, look, I'm sorry, this happened. What can we learn from it? This is what we're gonna do differently. And it really makes it really makes a difference. So
Tanvir, talk about a little bit about that too. I think that makes you guys a little bit different in that we're facilitating callbacks based on the bot is, and actually creating kind of an appointment, a personal appointment with your team. But you don't wait for that. Sometimes you see the comment, because you're using it on a daily basis, you'll pick up the phone yourself.
Yeah. So sometimes I'll see stuff like, oh, I called the cardiologist and they can't get me in for 2 weeks. The doctor wrote a prescription for me, but I'm still throwing up. So then it's like one of those, I'll pick up the phone, I'll change the prescription to like it was like rectal Phenergan instead of oral Phenergan. And then the other one is like, then we actually call our cardiologist and say, hey, our patients are telling us that's taking about 2 weeks. You guys promised us, 48 to 72 hours. What's going on here? And then you can really start fixing processes. And then if you see that patient, you're like, wow, that patient should not be waiting 2 weeks. You may just get on the phone and make some phone calls yourself, or have somebody try to get that patient plugged in sooner. So we use Epic as our EMR, and we have like a lot of secure chatting. So then I'll just be like, I'll send a message to the office manager from the cardiology practice saying, hey, can you really get Jared in? He's saying this thing can take 2 weeks, and please close the loop with me once that patient has an appointment. And then we'll call and say, hey, I see we got you that appointment sooner. And then that's really, it really kind of, there's no way when you're seeing that many people to know if everything is working perfectly. Are we really delivering seamless care? And that's our goal of our healthcare system. That's our goal. That's my goal in the ED, to have patients have seamless care. And the only way to know that is to get data points and feedback on when we're not delivering on our mission. So I won't bore you with all of this stuff, but it basically says that it's been working. And it's really a tool for that, so, we'll kind of, this is so Jared and I will kind of open up to Q&A and questions and some of the challenges and things that we've learned along the way and how we're continuing to learn as we go along. And that's one of the beauties of I really enjoyed working with Jared is, he's been really receptive to helping change anything that we need. So if anything, and he's a curious guy. I like to work with curious people because it makes it like, okay, well, how can we do this better? What problem are we really trying to solve? And we don't always have the answers. And by being curious and reading these comments, the consumers are telling you what the issues are. And if you're open enough, if if you have an open mind, you can really kind of help serve the patients and serve your mission. Jared?
Yeah, no, I agree. It's why we kind of exist. I mean, we're really just our job in this whole thing is, I mean, you're doing, 95% of the work. What we do is just create a window of opportunity, right? To allow you to make it easy to scale and actually have the patient give feedback in real time when the time matters, right? And context is king, right? Like the next day or 2 days later is really when everybody kind of understands or has a understanding of, at least from their perspective, what happened. And I got to say, I mean, in terms of like this, you don't have the slides up anymore, but our scores, our Health Talk scores, are mapping exactly with Prascani, and that is essentially you guys are doing outstanding work. I think it was something like 61% had very positive comments. We don't see that anywhere, but like I said, it goes hand in hand. We're the tool, but without the leadership at Inova, right? In terms of having a practice of now what we didn't talk about is like some of the things that go to the staff. So we have clinical engagement where we're sending reports, twice a month to those physicians with their scores, their comments. They can log in, get that real-time feedback. So it's really about the whole program. And we're really just excited 4 years later to be still partnered with you guys. But yeah, we'll take any questions if you got them.
Well, I always have questions, so
Okay.
I'll start. But if anybody else
Great.
has a question, please raise your hand or throw it in the chat and I'll be monitoring both. So the first, and I heard you talk to it, Tanvir, that you are still doing the official Prascani survey as well. So you're doing both. Can you tell me a little bit about the complications that might be for your team? Because now you have two different surveys coming in. Is there any confusion from the team about the two, or is it that this one from Health Talk is really giving you the more real-time, actionable, and then the results from Prascani come later?
Yeah, I agree. It's exactly what you said, Denise. They're more real-time, actionable, like a platform they can log in daily. Pressgani is more of a lagging indicator. So, if so it's harder to really understand some of the independent variables that are creating the problem. So, so that's why like sometimes we'll do recovery and they'll show up on Pressgani. Somebody did reach out to me and they fixed the problem. Thank you. And and this is important to healthcare systems, it's important to boards as they're looking at it. There has to be a sense of pride in the care that we're delivering down there, but it has not impacted our overall response rate from Prascani.
Mm-hmm. And I heard you and Jared before everybody else came on, that there's flexibility in the questions. So tell me a little bit about how you're selecting the questions that are being placed in, and then what is the decisioning for when you might change those questions?
Yeah, I'll take a stab into our approach. So what I learned in healthcare 30 years in healthcare is very local, right? In terms of it's local to region, it's local to facility, to department. And so early on, I knew that we had to be highly configurable, right? Mm-hmm. And so we go in really with a consultative approach. So what we did with Tanvir, like you said, is that we work together and saying, well, what do we know about right now in terms of what Prascani is telling you, right? In terms of the problem areas that you're having. Mm-hmm. And those came up with those 3 domain type questions: quality, quality, operational was around the facility, and the third one was around the physicians. Like, what do you think your physicians, right, in terms of that? And then based on that, we would schedule a follow-up, our customer recovery call, the bot would, in terms of that. But that morphed because they solved those problems, right? So that went into the 2.0. But yeah, we use a consultative approach. We have kind of banks of questions that basically apply to those different problems, and usually it starts there, but usually folks tweak it and they message it based on what they want to say, what they want to convey to their patients, and solicit that feedback in a way that's most appropriate to them. And that's exactly what we did at Inova Fairfax.
It looks like Joel asked a question. He says, do you all also call back some of the patients that rate their experience really high? Being able to get more context on what the team did really well could be helpful to them.
once in a while, but I think that's something we think we all do better is like focus on the high performers as well. But it's an option that you can call wherever you want. It's flexible depending on your bandwidth.
Mm.
But it's interesting. Sometimes what I'll do is like some doctors who are struggling, I'll ask them to call patients that are doing really well first to start building up that rapport and having the conversation so they feel more comfortable. You don't want to throw them to the wolves and have them call the patient who has like the worst experience because that may just be not very good. So
Mhm.
from a coaching opportunity, that's something that we do talk about.
Mm. And
Yeah.
how,
I was
I'm
just
sorry,
going to
Jared, go
add,
ahead.
we do have some other health systems that are asking a follow-up question there.
Mm.
So basically kind of capturing that in terms of in terms of what went well. I think that's a great question. And then we do have some health systems also that when we're using our bot, right, to instantly know what the patient's kind of score is, we will push them to whatever social media site, their Google reviews, or so the folks that has had a great kind of experience, hey, please, great, you had a great experience. So they're getting a message back from the bot that says, great, you had a great experience. It's really important for our community to know that we're doing great work. Would you mind leaving a positive review? So we have probably half the health systems that are using this to kind of do that. We haven't done that at Fairfax, but those two things that we have done with positive results in terms of that. But I know Tanvir is using the positive results, right, Tanvir, to retain folks, to give them notoriety, or at least that pat on the back when when the physicians are doing a great job and they have really high scores with HealthTalk.
Yeah. Yeah.
And is this currently only used in the ED, or is it being used in a clinic setting or with discharge from the hospital for an inpatient stay?
Yeah, that's a good question. So yeah, we do a myriad of use cases on setting to setting. At the end of the day, the questions from a health talk perspective don't matter, right? It's about identifying a gap in care. And this one happens to be around quality and patient experience, but we have other use cases around transitions of care where we're basically finding out whether the patient has a primary care provider, where we're 30 a third of the population does not, and then we're keeping them within network. So we're offering up a visit within primary care. We do that as well as we're in primary care. So we about half of our customer base is within primary care, where they can scale that outreach for either patient experience or doing that, but also, hey, it's time for would you like to get your colorectal screening done? Would you like to get your mammogram? So there's endless amounts of gap closure to do, and therefore other segments within healthcare that we are live with today.
And then tell me a little bit about, this is a text that they open and start the conversation with a bot. How are you collecting the cell phone numbers, and do the patients know that they're going to receive this via text? Do they have to opt in to be included?
Well, I mean, so it is an opt-in. So we recommend that all of our engagement, you have the option of, hey, would you like, I think if you have that slide, I don't know if you saw that slide, Tanvir, or maybe I do, but basically the patients ask, hey, we'd like to improve our care. Would you answer a 3-question survey? So they can opt in there. That's kind of where that is. Every health system is different in terms of, some folks are adding it to their, to the consent to treat, right? Their consent to treat, hey, can we text you? You don't need to. Telecommunication protection, TCPA kind of covers provider organizations. In terms of getting the phone number, it is in a feed or basically a discharge list, right? So basically we can gather the phone number. If you go up, I think if it's a slide with the phone number, with the phones, yeah, see it. So that was it. So here's an example of the opt-in. So if they were to say no,
I
hey,
see.
if they say no, the bot would say, okay, we understand. We would
Mhm.
stop. Right, we would not ask them the question. So we highly recommend this. Barrel Institute talks about an opt-in, and Mayo Clinic talks about that as well in terms of that. So we have that capability in terms of they can opt in. But yes, we get the phone numbers from registration, right? At the time of registration, there's a bunch of things around phone numbers we can talk about, because we are a text only platform, because that's just how patients. We experimented with other channels, but that's really how that we get the highest response rate and completion rate in terms of that.
And do you know what the opt-in rate has looked like?
Yeah, so for Health Talk across the board, we have over a 35% response rate, right? And so then we have something like close to a 30% completion rate for myriad of use cases. And that's, if you look at the studies, that's like, 10 times the you guys know this world, right? In terms of unincentivized, unsolicited surveys, it's very good. And the thing is the approach to the technology, and our approach is we have to make it easy for patients to engage. So we're really about no apps, right? Unless it's absolutely necessary. If we have to do, and if we have to do a telehealth follow-up, like we're doing with Inova, we send the patient a link. We make it super easy for the patient to engage. There's no logins or anything like that, because, those logins and passwords and are really barriers to care. That's the way we look at it.
And we've got two questions in the chat. So one is PX survey, is this PX survey have impact on other clinical measures and readmission rates to the ED?
Yeah, so I don't think we have it on this one, but I think Dr. Bahar talked about that you guys had reduced your 72-hour returns, right? I think it was in some time frame. I think it was during COVID. I don't want to quote it, but your 72-hour return is pretty low now, right, Tanvir?
It's very low.
Nice.
So in terms of, this is really customizable to whatever you want. If you wanted to, we've chosen not to do it at Fairfax because, but you could even survey patients that are admitted to the hospital as well. So there's different ways of utilizing it. This is really kind of customizing it to what your needs are. So Jared and I've looked at other hospitals where they've done more inpatient, where patients get admitted and they get discharged, and they can say, did you get follow-up or whatever it is? Did you get follow-up with your specialist? So that way you look at 30-day readmissions. So
yeah,
so it can be done whatever way the needs are.
Yeah, I mean, I think there's we are doing inpatient surveys in terms of patients that we're seeing in-house. The questions are slightly different, right? In terms of that, obviously they're different, but yes, we're doing that now. We're not doing that at Inova though.
Okay. So another question is, what is the timing difference between the ED bot survey, so your survey, and the Press Ganey survey?
So I think at Inova it's 2 days for us, and I'm not sure, but that's what they've just decided to do. We can do it as early as the next day, but I'm not sure when your folks are getting the Press Ganey survey. Do you know, Dr. Gabi?
Yeah, we do texting and mail, so they're getting them probably 1 week out.
Oh.
All right. And then Joel asks, I know this was highlighted, the ED. I was wondering if you all have done anything like this in an inpatient setting, as there might be some rules from CMS if questions are too close to the HCAHPS questions. That's very true. You're right.
Yeah. So one of those things is that's why we made sure when we did our scaling scores that they didn't mirror Press Ganey. So he's absolutely right that you want to make sure that the questions are not the same, and that's why we use different scaling systems as well.
Excellent.
Yep.
And so this survey with your EDs, it's only going to go to those patients who were discharged from your ED. Those patients who, of course, admitted are going to end up with the official HCAHPS survey. Nothing from health. Okay.
Correct. Yeah. But like Jared talked about, that you can do that because the ER patients are still getting ED-CAP surveys. So they are getting 2 surveys. And then the way Press Ganey has they have a little different algorithm of who they send it out to as well.
But Tanvir, I think the big problem is, right, in terms of the ED versus that. So I think the thing that we don't want to highlight, the takeaway is that the patient gets our survey closer to discharge, but the data is available to you, whereas Press Ganey may not be available to you. How long afterwards? And it's missing some context, right? Press Ganey.
Right.
Yeah. So that's the other thing. Is that Press Ganey doesn't tell you. Somebody leaves a comment, you don't know who it is, right? So, and that's like he was saying,
because Press Ganey makes it really hard to go back and find the patient because they really want to keep it like anonymous. So there's ways of doing it, manipulating the data that you can get CSN numbers and there's doing it backwards. Again, this HealthTalk is more about the team being curious to what the consumer's saying, and then if you're open to taking that feedback to really making tangible change, and the output would be Press Ganey, you'd see that down, like you saw through our journey over the last 4 years. We started off one place. We didn't go in saying HealthTalk's going to help us fix our Press Ganey. We went in saying HealthTalk's going to help us understand what our customers are really saying and give access to all the team members, right? Because the difference with Press Ganey is like everybody's not going to get access to Press Ganey. You get limited licenses. With HealthTalk, is like you can have all your team members have access, log into the dashboard, look at their own comments, and see what's being said. And it's something that you can track on a daily, like a visual dashboard every day. You're looking at it. So there's some subtle differences in terms of what the intent really is. So because we've paid attention to what customers are saying, the output's been quite good. If we just said, "Oh, Health Talk is just gonna be an engagement survey," that's gonna, just tell the patients. I don't know if the scores would have been. I think they would have gone better, but I don't know if they would have got that much better. So you still have to use that data to drive change, drive process change.
I
think
know
it-
that. I'm sorry. Go ahead, Jared.
No, I was just going to say that I think that I think I can, I mean, he obviously he can't bring up, his dashboard because that's PHI, but I can bring up our demo, right, in terms of what he's talking about. So every clinician has access to this. They can get that on their phone. Like you said, we're sending this out, their scores, all the providers anyway, every 2 weeks. But this is where you can, these are those 3 questions where you can actually slice and dice this based on what's happened. This is demo data, by the way. This is not, has no PHI. But really you can see based on location. So you can start to dig down to, zip code, like he was saying, in terms of, he showed a slide of this, but here's where, you can see the provider name. You can really dig into these comments. We use AI to kind of give a score around that. So like you're saying, so when he's talking about that, he's giving ownership to each provider and each team member to say, okay, well, what are people saying about me from a comment perspective? What are they saying about me from a score perspective? And how can I kind of see the patterns of what patients are saying about this? So this is what the dashboard that he's talking about when he referenced this, the dashboard and the tool that they're using. I mean, and then from the practice perspective, there's a lot of tools in terms of raw ranking. This is based on payers. You can look on based on, ethnicity. You can based on, providers. You can raw rank in providers. And then there's all different types of dashboards of analytics. It doesn't look sexy because this is essentially demo data, but benchmarking some things, looking at care groups. There's a lot of data here, right? That the providers, when they have the leadership like they do at Innova, they're providing the tools that allow them to get better, or the tools to say, hey, to prove to them and everybody else that they're doing world-class work.
That's I loved some of those demographics that you can click on to get an idea about the different perceptions based off the demographics. That's really cool.
Yep.
And it's so easy. One of the reasons why I was asking about who gets the survey, and of course it would, from Health Talk, it would go just to those who had discharged, is, I worked with Press Ganey a few years back. So I was on their team. So I do know that we have data, they have data that shows patients who are admitted from the ED tend to have lower HCAHPS scores than people who were direct admitted. And so whether or not you could influence the HCAHPS by doing almost like a service recovery, right? If you have an idea of what the experience was in the ED, if you could connect with the patient and resolve some of that.
Yeah, that's what we're doing. That's what
so
we're doing.
you are surveying those who get admitted to
not in Tanvir's case, but in other cases.
Jared, I know, Denise, you're absolutely right. What Press Ganey and everything has shown that the hospital HCAHPS will mirror ER Press Ganey scores or whatever ER patient experience scores. So by fixing this problem, our hospital HCAHPS scores have gone up as well.
Okay.
Yeah. So 70% of the admissions, 60 to 70% of the admissions through the healthcare through our hospital come through our ED. So when our scores are doing well, that's reflected in the comments upstairs, and so the hospital looks at both. So there's a direct correlation. So if you improve your ER patient experience score, you're really going to see an improvement in HCAHPS as well.
Excellent. So I'm just checking. How did you approach engage the ED providers in embracing this tool? That's a really good question.
We brought a club and said no. Look, one of the things that people want transparency. We tell them like, look, this is something that's really important. And as a leader, I often talk to people about why I went into healthcare. I went into healthcare because growing up, I had parents who often we had to go to the doctors, and I would go with them. And so it was just that there were some experiences where people just they didn't communicate well. And so you, as a young adult, you're taking days off to go with them, missing a day of college to come because your parents didn't really understand something. So I tell people like Press Ganey, look, it's really important to the hospital, but it's really important to me. It's important to me because it's really a reflective of how you're communicating. It doesn't mean that you're going to be perfect. Are you going to be open to hearing what people are saying and trying to get better? If you're not, then this is not the right cultural fit for you. But if you say, look, I get, I use one of the data, one of the Press Ganey, one of the Health Talk comments was around a nurse practitioner who was put in a hallway patient. She waited 3 hours in the waiting room. She got put back into a hallway spot, and then the clinician said, "I know you had to wait a minute." So I went back to him and I said, "Look, what do you think about what this lady said in the comments?" And he's like, yeah, maybe I shouldn't have said a minute. I'm like, but let's really unpack that. What's really the issue here? And he's like, "Look, I get really anxious, but I don't know what to say to people in the hallways. I feel bad. I don't know what to say to them." So then there was more of a curiosity. Okay, how about you say, like, I know you've been waiting a long time. I'm sorry you're in the hallway, but I'm gonna take real good care. Now that you're in front of me, I'm gonna do everything I can to try to get you through the system efficiently.
Mm.
And so he actually incorporated that, and and he said that's what goes back to what Jared and I are talking about with coaching. And he said, Tanvir, I feel a lot more comfortable talking to patients in the hallway now. Like they get it that I'm not, it's not an ideal spot, but they know I'm trying my best. But it's interesting because if somebody's waiting 3 hours and you say you've been waiting a minute, you're like, no, idiot, I've been waiting 3 hours. So, so I think what Jared and I really been talking about is whoever, as you implement these programs, it really has to be leadership buying into why it's important. And then
Well,
staff will be off of that. They get it.
yep. And Tanvir, what I'm hearing from you that really strikes me, it's one of the things that I share often. The tool that you're using isn't going to solve the problem. The tool can enhance your ability to receive insights, but it's leadership, Tanvir, such as what you're demonstrating, the coaching that you're doing, the elevation of your team in the process. And so this is a great tool to help a leader such as yourself. And it takes leadership really being bought in and all in on how do we use this data to act and improve upon what we're hearing.
Well said, Denise. Thank you. Yeah.
Yeah, I will say one other thing too is from this side is, we're looking for folks that are looking to transform what they're doing, and I have conversations weekly with folks that are out there saying, we have I talked to a health system. I won't mention them obviously, but we have 50 nurses that do this work, and we like that. And so we're not for them, right? In terms of that, being able to scale that, in terms of being able to, Tanvir obviously came to us from like, we can't call our patients back, but we like to, but we can't. So there's a realization of the forward thinking of, how can we use automation and really in the low level AI to say, how can we reach as many patients as we can and actually facilitate a callback where we need to. But there are still folks out there today that are like, no, we like our 50, 100 nurses calling patients, and for that regard, we are not a good fit.
So there was a comment that you had made, Tanvir, as you were talking, that I wrote down the word challenge. So it sounded like that there have been opportunities through this process. So I wonder if you can tell us a little bit about what does it look like to implement something like this? Where did IT get involved, et cetera? And what are those lessons learned that perhaps, Jared, on your side, you've learned, and Tanvir on your side?
Yeah, honestly, for that one, I would say, the healthcare systems, one of the things they wanted to know initially was going to impact the number of surveys that they were going to be able to, their response rate, and the answer to that was no. And then, PHI data, was it going to be protected or not? And I think Jared, in that sense, is a great partner where it really kind of answered a lot of those questions. A lot of healthcare systems are really sensitive to potential data breaches and things that may happen. And, I think Jared, with his background in the team, this is obviously Jared and the team. They obviously have some wonderful people behind the scenes who really make this product successful. Jared, you want to talk about some of the things, the challenges that you often hear, and then you have like FAQ saying, I know this is going to come up, but this is how we're going to deal with it.
Yeah, I think you mentioned a little bit ago with your staff. It's transparency. It's like, this is how we handle data. This is where it lives. This is where it goes. It's your data. This is how we're secure, and basically allowing them to poke and potentially, it wasn't necessary with Nova, but some folks want to stand up an instance of it and go through the security component of it. So I think it was. I think it was, that was obviously, security is always a big component. It's always our hurdle that we have to cross, but it's part of it's table stakes in health IT at this point. We're used to that, and so it wasn't anything out of the ordinary for us. And we just make our people and our policies and our stack as transparent as we can, so that everybody feels and knows that we're handling their data with the utmost strict security.
Mm-hmm. And Jared, you're not offering any of the CAPS surveys in addition. So it really does require a Press Ganey to also be doing any of those types of official surveys.
That's correct. We're not going to be I think there's 41 vendors out there that are qualified by CMS to collect the data, and we're not one of those. We're the front windshield for you. We're not going to be the report card. We don't. I don't foresee us getting into that space in terms of that. We're really about, like I said, helping health systems and health centers create an opportunity and gap closure. That's really what we're about. And we do it close to, around, or before, that actual encounter. Right. So it's all relevant in that regard, but no, we're not going to be a Briskanian. Yet you do absolutely have to do both in terms of that.
Hey, Jared, can I make a comment?
Yeah. Who's talking?
Hi, how are y'all? Yeah, this has been great, by the way. This is Joel. Yeah, I've been consulting in some of this space for about 15 years. So one thing that y'all could use. So one of the things that the last firm I worked for was very successful in was patient callbacks from staff. However, the focus was on the follow-up. It wasn't about the engagement or the experience. It was more like, hey, Jared, were you able to get your scripts filled? Do you have a follow? It was more about quality, right? And I'll tell you that there are hospitals that make calls like this, like the bot does, and there's really no evidence that all that FTE that you're putting to that does anything. However, what you're doing is awesome because it's getting the data that you don't get out of there. Like, for instance, any hospital I used to go into where they had, like you said, 50 nurses making these calls, asking them, hey, rate this 1 to 5, 1 to 5, whatever. They didn't show any benefit. Now, they were spending a lot of money, obviously, right? So anyone that they were doing kind of the rating calls, I would typically consult them to either change that over to focus on quality or just stop altogether, because you're spending the money and not getting the benefit. Whereas this, it looks like and I love what you're doing because you are getting things closer to the patient experience. I get, Dr. Gabi, to your point, I get something in the mail a week and a half from now. A lot's happened since my ED experience, right? So I think that's a big way that y'all can continue to differentiate. Where when people are saying, "Oh, I have a ton of people doing it," I mean, my answer would be, "Well, you're kind of spending a lot of money in the wrong area, and maybe not getting the results."
Well, yeah, that's exactly right. I think, and I would love to connect with you, Joel, at some point afterwards, because you guys are doing a lot of the heavy lifting too. Because unless the folks have been highlighted by somebody like you that's saying, hey, you know what, it's maybe a better way. Sometimes it's not credible coming from the tech company, right? Saying that, but being coached to say, or being consulted to say, there's a better way, and here's not just HealthTalk, but here's a couple other folks that are in the space. Goes a long way to that transformation process. So 100%, we're always looking to get better at what we do. And yeah, we are all about the outcomes. That's why I love that slide that they did around the Briskani scores and the willingness to recommend going up over time, right? Because a lot of times you see that you have a big boom in terms of impact, but then you kind of drop off afterwards in terms of that. So they're being able to sustain that. And I think a big part of that is the flexibility, being able to ask different questions based on now over the years that they've been live, having different problems. So, but yeah, 100% agree with you, Joel.
And what really stood out to me when you showed the data set, Tanvir, was those years were inclusive of COVID, and they continued to go up. They did not go down.
Yeah. It's impressive work, right?
Yeah.
And I think it's and it's, we're talking about a level 1 trauma center, right? We're not that other folks don't have similar issues. They do, but level 1 trauma centers have their unique kind of set of problems, right? In terms of that. So it's very impressive. Like I said, and Tanvir and his team have helped us make the product better, right? So they've are continuing, sending us little thing. Hey, can you do this? Or what if you did that? Or can you add that? And we're like, absolutely. Like, if you're having the issue and we're not able to, display something in real time, and you want to see that data set, everybody else is going to benefit from that as well. So they've been great developer partners along the way too. That whole comment analytics that we showed you, where we score the comments, that came from Tanvir's shop, where it was too many comments. 25% of patients leave comments on our surveys because all they have to do is text back, right? It's like super, yeah, hey, is there anything you'd like to add? And they text back. The problem was initially 4 years ago or 3 years ago was that it was just too many comments. You couldn't discern which one was positive and negative when you're looking at scrolling of screens. If you're looking at 3 months worth, it just didn't mean anything. So we actually added the AI where we actually are reading the comment, and we actually put a score to that comment, negative or positive, in terms of that. So that's a good example of Tanvir and Innova helping us make the product better.
Well, on that note, we have come to the top of the hour. So that went by quickly. Thank you both for sharing so much with us. Jared, how can people reach out to you if they would like to know more, to connect with you?
Yeah, I'll put it in the chat here. Put my email.
And then
That's
I
great.
will also, Jared, share that when I send out the follow-up from this. So this recording will get slightly edited, and I will ensure that each of you have access to that if you want to be able to use it elsewhere to show somebody else. But you'll also have Jared's contact information, so you can reach out. So you'll get it in both ways there. And now we get to transition to speed networking. So Jared and Tanvir, thank you so much for the time and knowledge you've shared thus far. And I'm grateful that you're going to stay with us for speed networking.
But I am curious as to the culture,
Yeah.
how the culture has shifted from in the last 4 years, from when you initially brought this on until now.
No, it's interesting because we have this one doctor of mine that I was working with, and she was just like really struggling with patient experience and tried a bunch of different things, and it was getting to the end where I thought I was going to fire her. And I had a conversation with her, and she's like, "Well, why didn't you just tell me that this is important to the hospital, or else I'm gonna lose my job?" I said, "Look, if that's what it's going to take, because clearly the connection's not there." And then she said, "Fine." So she started. So I said, I need to log on." So slowly her scores started improving, like little bit by little bit, like little engine they could. She started getting warm blankets for patients. She works nights, and she's like, "Oh, I'm a 1 percentile, and it's a night doctor thing." Anyway, long story short, she started slowly improving. Finally took it seriously, started improving, and to the point where now she's like in the 99 percentile. And when it's so funny when you talk to her, now we can laugh about it. Like this is 3 years later, and she says, "I'm actually now asking, like, are you happier at work? Like, do you feel like you're connected to your patients more? Do you feel like you're finding a bit more purpose in your patients?" And she'll say, "Yes." And then she's like, "Yeah, I don't know what I was thinking." So she's actually becoming like one of my champions. She'll say like, "Hey, you know what? I was a little whiny about it, and now after having gone through the process and transformation myself, I really feel like better about work." And so I think that's where unfortunately, fortunately, that's why it's called leader. You have to kind of really get people to buy in. And really, the culture in our organization is really good. They don't really like, they're more like, you can make mistakes, not a problem. You gotta learn from your mistakes, but you just can't stay at the bottom forever. Like, we need to see that you're making some progress. I've been part of other organizations or seen other organizations where like, just the runway is like forever. At some point, the plane needs to take off. You can't stay in the runway forever.
Yeah, I think that's great. And I think that that's a great story to help promote, engagement with this patient feedback tool when you have a naysayer or somebody that was such a challenge. And then not only are they improving, but they also are finding that their work is more rewarding now and they're more satisfied. So yeah, good stuff.
Thank you.
Culture eats strategy for lunch, right? And so it's about that. And we have some other health systems where we go in and they say, well, who's going to see this data? And it's like, well, everybody's going to see the data. And so there are some folks that are concerned about that. And, either they get over it, or we do have permissions, and some folks can see stuff and other folks can't, but eventually they open it up to everybody because they realize that really that's where the tool is the most powerful, is when everybody's looking for the same lens, right? In terms of that, not just this person sees that person. Obviously they're the customer. They can do what they want. They can say, only patient experience can't see the doctor's names. We can make that that way. But Tanvir has an open kimono kind of policy over there, so everybody can see everything. So it's really it's all about leadership and culture. And
well, and it's the transparency and the mirror, right? Like there was a study that was done years ago from police departments, and they were trying to, actually, I'm not sure if it was a police department that actually conducted the study. It was a social experiment, and they were trying to find out what was the biggest deterrent to people speeding in cars. And of course, everybody would have thought what all of us probably think, which is a cop car, right? And it's actually not. That was, I think, ranked number 2. The number 1 deterrent was the speed limit sign that also shows you how fast you're going.
I love that.
Yeah,
love that.
I thought it would have been a cop car because that's what slows me down. But
I may steal that. That's great, right? I mean, it's a good analogy, right? Because you can kind of see what you're doing, right? Instead of in real time.